Welcome to another edition of Inside Humane Medicine. I'm your host, Henry Ford, the Dean and Chief Academic Officer of the University of Miami Miller School of Medicine. Today, we are discussing one of the more challenging problems in neuroscience, the diagnosis and treatment of Parkinson's disease. From the groundbreaking use of artificial intelligence for early detection to implanting stem cells or using deep brain stimulation for treatment, this episode will explore the contemporary approaches to the diagnosis and treatment of this vexing disorder. And to help us navigate these complex developments, I'm thrilled to welcome to the studio Dr. Ihtsham, the Professor of Neurology and Chief of the Division of Movement Disorders at the Miller School of Medicine, and truly a world-renowned leader in the field of movement disorders. Dr. Hack, welcome. And thank you for agreeing to speak with us this morning.
It's my pleasure to be here.
Yeah. But before we dive into the subject of Parkinson's disease, please tell the audience a little bit about your journey and how you became interested in medicine in general, especially growing up in Brooklyn, Father.
Oh my goodness. So I think it's always interesting trying to tell someone's story because you construct the facts backwards, right, from who you are now, but with that necessary caveat. I mean, I feel like I've always been drawn to neurology and to the brain. I don't know. I just grew up watching nature specials and wondering how things worked. And very quickly that became an interest in how people worked and, why we did the things we did, why we made the choices we did, why we, were the people that we are. So that grew throughout childhood. And by the time it came to choose what to do in college, I found that I couldn't choose. So I didn't, in a way. At Columbia, I did dual degrees in bioengineering and philosophy, so sort of both the mechanics and not.
So that's an interesting combination, bioengineering and philosophy.
Yeah, it was a bit of a sell to my parents. So I didn't really buy at the time, but it seems to have worked out okay.
Renaissance, man.
Oh, that's very kind. So I took that then and took that with me to medical school, which seemed the easiest way to both continue to work with understanding people and also helping people. That had always been important to me. Something my parents instilled in me early on, the idea that, whatever gifts you were given, you needed to use them to give back and to do good. And that was really the only way to be happy. And I think they were right.
But of all the disciplines that you could have selected, why neurology? What inspired you to pursue neurology?
Well, the brain for me is the most fascinating of the different things that make us where it is who we are, right? Like that 2.5, 3 pounds of pink tissue in our head is everything. The other positions you have here potentially will disagree. I understand the need for pumps and for waste filtration, but in the end, I would claim that it just serves that need.
But was there a time when you came to the realization that the brain was the most important organ to study? Was there a pivotal moment that made you more conscious that those 3 pounds of flesh in that skull, hover just about all the important...
That's a great question. And so I have to think a bit. I think that, like I said, you construct your narrative backwards. So I think there are a couple of pivotal moments, right? So the ones that I immediately come to mind. So seeing a patient during medical school, I don't know how common it still is to have patient demonstrations as part of teaching. I hope it's still common because it's meaningful for sure.
Still happens.
Wonderful. We had a patient who had had a stroke and they came and the professor very gently and respectfully showed us how to determine where in the person's brain and spinal cord these issues were coming from. But the fact that the person had these issues, right, that there was a change to the way they were able to speak, and this struck me, not just the way they were able to speak, but the way they were able to think of how to speak in the first place, had been definitively affected by physical changes in their brain, and they could figure out where that was just by talking to the person and examining them. And that was, in an era before we really got to where we are now, where we not only could analyze and understand the brain, but actually potentially make changes to help our patients. So once I saw that, it was neurology for me.
So I always like to think that a neurologist is the ultimate detective because you got to see what's going on and figure out where the malfunction occurred. But so let's fast forward now. Given all the various subspecialties you could have selected in neurology, why did you select movement disorders in general?
No, I'm happy I did. A lot of what happens in medicine, I imagine, if you notice the same in your own trajectory and career, is who you happen to spend time with, right? But I did happen to spend time with a lot of wonderful neurologists at a very specific time in neurology. So deep brain stimulation was something that was sort of coming up in the world during my residency. What is DBS?
Yeah. What is deep brain stimulation? Dude, that sounds scary.
I want to make it seem less scary so more people can benefit from it. But it's putting electrodes into people's brains. So deep brain stimulation, sort of the...
Why would you do that?
Because you want to be able to change how brains work. Brains are electrical systems, so the easiest way to change it, the most direct way to change it is to change it, to put an electrode down there and to change the way it works.
Okay, continue. So somehow you decided that this was the exciting field that you wanted to pursue.
Absolutely, yes.
So tell me a little bit about the landscape at the time that you selected this particular discipline. What were the tools? What did it look like? And
oh my God, it was so different. I think we've all seen how quick...
I mean, you're pretty young. You say you were so...
Well, that's you. My kids don't think so. And, there was a time when I thought 22 was like the oldest thing on the planet. But, thank you. I've been around a minute. You were asking about the landscape at the time. It was different. So, if you think about compute power, for example, right? Like this was an era maybe 10, 15 years after personal computers even popped up. This is an era 6 or 7 years after the internet began really in its modern instantiation. This was an era we were maybe 5 or 6 years out from using MRIs to detect acute strokes. An exciting trial was still being able to treat a stroke as an emergency that you could actually bust the clock for. So this was an era when neurology was changing really, really rapidly. DBS was part of that. This new thing where you could put electrodes in and change the way a person behaved was all part of the tumult around that time. But it was caveman days compared to now.
So you mentioned Parkinson's disease as a prototypical movement disorder. So just tell us a little bit about this disease. Tell us how do you get it? What causes it? And what are the underlying problems that lead to Parkinson's?
I'm only smiling because, Dean Ford, any one of those questions could take us the rest of the time easily. And we're not. So this is what I'm going to try, but this is what I spend my life doing, right? So I'm going to take a moment to kind of dial in on one thing. So this is what I'm going to start with. Parkinson's disease is a clinical diagnosis. It's a set of things that people show us, and we call that Parkinson's disease. And the last 5 or 10 years have been figuring out how lots of different things that we potentially can adjust and change end up looking like that one thing. Parkinson's isn't cancer, so when I say use cancer as an analogy, as I'm about to, I don't want to mislead people, but like cancer, it's this big concept that has lots of things feeding into it, and it matters which one you have, because like different kinds of cancers, they probably have different treatments, slightly.
Sounds complicated already. But go ahead, give me a little primer.
Okay, so people have Parkinson's disease when they have slowness and stiffness, more on one side of their body than the other, typically. So, the pretty classic description of a Parkinson's patient would be, for mine, I noticed I went rock climbing and my arm just has kept feeling stiff ever since then. I figured I pulled it, but it's been 7 months and it still feels like it's pulled. People think of the tremor, and they purposely haven't mentioned the tremor. That happens about half the time, but half the time it doesn't. Half the time it's the story that I just mentioned, but it'll also be the people who come in and say, I've noticed that when I sit there, not when I'm using my hand, but just when I sit there, my hand shakes a little bit. And those are the people who realize there might be something going on. They come to us, and then we help them.
It's pretty, so it starts with the stiffness you mentioned.
Yeah.
So by the time we get tremor, that means that things are a little bit further along.
This goes back to the idea that there are a lot of different things that are all calling Parkinson's. It varies a lot. There are people who will never have a tremor. There are people who never really notice their stiffness. It depends.
And typically, what age do people start getting worried or starting to think that something happens, and what triggers people to actually even get evaluated?
Yeah. So I'll give you a range and then sort of a mean. So the range, I mean, I've seen patients as young as in their 40s, and people get it in their 30s. And I've seen people as in their 80s and even 90s who are developing it for the first time.
So Michael J. Fox got it pretty
Very young.
kicking.
Yeah. And my goodness, the impact he's had on the disease. So what a way to turn what could have been and is a profound difficulty into an achievement. But most people probably around the age of 65 or so.
So what is the problem with the brain that leads to this manifestation of the symptoms?
To put it simply, the signals and control center isn't working quite the way that it should. So there's a compound called dopamine in the brain. Lots of people have heard about dopamine. Dopamine does lots of things. Depending on where in the brain you are and how it's working, it could be mood, it could be maintaining your emotion, and it could be movement.
What releases the dopamine? What makes it? And how does it get there?
It's made by certain cells in your brain, over in the back part of your brain called the brainstem, something called the substantia nigra, because it's two basically black little strips. And it all gets sent from there all over the brain. For the middle part of the brain, where a lot of your movement control happens, what's called the basal ganglia, dopamine mostly is a key and a lock. Without it, you're stiff, can't move. Dopamine allows you to move.
So it unlocks everything, and so it allows the connections to take place.
Exactly. And if you don't have that key, you stay stiff.
Is it that there's a lack of production of the dopamine? Or is it that it's being produced, it cannot get there?
This reminds me of my patient discussions, because people ask really good questions, and we as physicians and scientists are asking exactly the same questions. Because the short answer is we know and we don't know, right? It's different things for different people. For most people, something is happening that's making the dopamine-producing cells in the brainstem die, unfortunately. And so it's primarily a reduction problem.
Globally, how many people are impacted by this disease?
It's huge. So it is the second fastest growing neurological disease and affects millions of people worldwide. It's hard to get exact estimates, but at least 90,000 or so new people per year are getting Parkinson's disease. So, I think some estimates have it in the multiple tens of millions in the next 10 or 15 years.
So I can understand why you would focus on something like that, because obviously it's quite significant and it impacts a large number of people. And you think it's growing. The number is growing.
It is growing. The number is definitively.
Why is that?
Great questions. Here, again, we have some thoughts. We don't know for sure. Some possibilities. We're better at finding Parkinson's disease, right? Like, people know what Parkinson's is in a way that they didn't 10, 20, 30 years ago. So maybe more people are coming in saying, I have Parkinson's. But even when you try to do things to adjust for that, it looks like there's more Parkinson's. So what is that? Environmental factors are probably playing a role as well. Our environment is changing across a number of different axes: heat, pollution exposure, particulate, plastics. All these probably end up creating an environment that's more fertile for neurodegenerative disease. Inflammation rates are up also. Everything that can affect your brain makes Parkinson's more likely.
You told us that there's a broad range of ages when we can catch it, from early to late 20s, early 30s up to 70s. Why such a large range, and what makes diagnosing Parkinson's such a challenge?
What a great question. People bring different things to the table, right? Different genes, different exposures. It is some kind of interaction between them. There are people who have monogenetic causes, who have single genes, who have a gene that, because of its impairment, makes them prone to Parkinson's disease. There's no such thing that I can tell as destiny for Parkinson's. Like, there's no combination of things that means you have to get Parkinson's, but there are some things that make it a lot more likely. So genetic causes, environmental causes are probably the reasons people.
How important is it to detect it early versus late? I mean, is there something that can be done?
Tremendously important, because like a lot of slow-moving diseases, and thankfully Parkinson's is a very slow-moving disease for the majority of people who have it, there's this long period where there is obviously less damage, and in fact, there's the rate of damage in some people is so slow, and most people is so slow, that usually the changes have been going on in your brain for 20, 30, 40 years before you show any symptoms at all. So that's a period where you could do something to prevent the progression, if not reverse it. It's certainly much easier to do that before damage has built up than to try to reverse damage.
The concept of damage, let's go back to what you said before. So the problem is that it's probably with the production of dopamine, or it's based on getting to where it needs to be to unlock and then allow connections to take place. What is the consequence of this? Is that nerve cells are dying in the brain, and because you just don't have that dopamine to allow them to talk? What is happening?
Yeah, by and large, in all versions of Parkinson's disease, you have your dopaminergic neurons dying for one reason or another. That is correct.
So the treatment, therefore, is to just provide dopamine. Is that
the treatment? Is exactly right. It's very logical. Our treatment since the 60s and 70s has been to give people a pill that becomes dopamine in their bloodstream. It works beautifully.
And that pill is called
carbidopa, levodopa. There are multiple forms now, but that is the classic.
And so why is that not solving the problem?
It does solve the problem temporarily. The problem is the same dopaminergic neurons that you have are banks. They make dopamine, but they store it also. So the storage capacity, your ability to hold on to the medication, to use the medication as time goes on, unfortunately becomes less. So the classic thing with Parkinson's is that the medication works great for the first couple of years. And then gradually, as your own capacity to hold on to and store it goes down, it lasts less and less long. And it's not lasting 7 hours or 6 hours or 5 hours or 4 hours. It's lasting 2.
But why wouldn't your storage capacity go down? What is the problem?
The neurons are the banks. If you don't have the bank, you can't store it.
Is they dying, and so you just facet. So since early diagnosis is so important, what tools do we have to get there?
Up until now, our tools have been our eyes and the training that informs that. So it's a clinical diagnosis. So clinicians, therefore, diagnose it. Clinicians decide if you have Parkinson's or not based on your being able to show them or tell them something that says you have Parkinson's disease. So first you have to have someone who thinks there's something going on, so they bother going to see a doctor. Then you have to have a physician who knows what to look for Parkinson's disease and doesn't decide it's just getting old. Because, like I said, you think you've pulled your muscle, it's lasting for 6 months, who thinks that's Parkinson's disease?
So it may take a year before you actually get the attention of a doctor.
Yeah, and to be clear, most of the time it is a pulled muscle. It's just sometimes it's not. The issue is, and this is why diagnosis has been so difficult, this is true, I think, across diseases. When things are mild, they don't look like much. That's the definition of mild. So there's a lot of things they can be. We're all familiar with, I think, as doctors in medical school, suddenly worrying that you have cancer because you have a cold, right? Like you're coughing, you're like, well, what if there's something growing in my lungs? There are possibilities, not likelihoods, yeah.
All right. So are there tools that we can use to accelerate the diagnosis? So there's some patterns that we can pick up and help the patient and the doctor get there faster.
Absolutely. And we're developing them right here at the University of Miami. Some work that I'm very proud of.
Tell us about it.
Sounds good. So, AI has gotten a lot of buzz, and I think justified.
Artificial intelligence.
Okay. As I think, a lot of people are going to be aware, AI is just the outgrowth of machine learning, an approach that's been around for a long time of using machines to look at patterns. It's just our capacity, machine's capacity to look at patterns and abstract from them is light years ahead of where it used to be. So if you can train a clinician to recognize a pattern, we're within striking distance of having a machine recognize the same pattern, and you can train it in almost the same way. We train clinicians by having them see lots of people with Parkinson's disease and look at videos.
Residencies, fellowship, that's how it is.
And then fellowship, in terms of getting good at the diagnosis of Parkinson's, is listening to a lot of stories, seeing a lot of people, but also learning to be a qualified rater of Parkinson's. So you look at lots of videos that are standardized showing exactly showing certain specific levels of difficulty, right? Like mild slowness of movement, moderate slowness of movement. So everyone agrees what mild or moderate means. it occurred to us that that is the perfect methodology for training a machine as well. And so that's what we did.
Are you telling me that we can use AI can replace the doctor now to diagnose Parkinson's? No,
Yeah.
seriously.
Yeah. Augment that.
Okay.
What we're looking for here. But
And how do we do that? I mean, how do you use that tool
so
to use?
we've had a couple of good
Augment.
We've had a couple of good partners. Amazon Web Services has worked closely with us. Slalom Consulting, in particular, is a large company that has done a lot of great AI work, has worked with us to make this a reality. And what we've done is exactly what I've described. It sounds very simple in concept, but it's been exciting to do. We've taken videos and we've trained a machine to accurately analyze them in the same way it would analyze a person.
So you break it down, videos of patients with Parkinson's, so we can instruct the system that this is what early Parkinson's is, this is what moderate. Well, is that what's happening right now for us?
It is. You kind of put the machine through a mini fellowship. Again, it's what you're doing with a person. Yeah. You can train people and machines in pretty analogous ways, right? And they're getting the machine learning works that way, right? Like it looks at patterns and somehow it figures out that this is the same as this thing, just as a person's brain does.
And this machine now can reliably, based on all the information you've fed it, it can reliably make the determination, make the prediction.
It's getting better with more and more information. And like fellows and like the rest of us, it gets better the more information it has.
And what has been your team's contribution to using this technology in Parkinson?
Well, as far as we know, we're the first to do it. So it sounds simple, but it's tremendously exciting to me because.
So what? I'm excited to hear about this. How did you arrive at that concept?
It was a need. So it has long bugged me, and I think lots of us in the field, how long it takes to train. Because one of the advantages the machine has is it's faster. It's a lot faster to learn, even if it is sort of an analogous process. So, there aren't enough movement physicians. How many trained Parkinson's raters are there out there? Well, if you've seen their movement physicians, we train maybe, and we're a big place, 2 or 3 new movement physicians a year. There are perhaps 100 or so new movement slots every year. There simply is no way to have enough people who know Parkinson's to treat the amount of Parkinson's out there. We need help. We need augmentation. That was the need. And recognition, early detection, grading, these are the things that we need to do to take care of people.
And were there specific guidelines that you had to employ in establishing the algorithms for the machine?
I think it is amazing that the tech people do what they do because there is a lot to discuss there in terms of different random forest models and their ingestion and other words that I don't really understand, but I can use. So they do a lot of sophisticated stuff to make the difficult look easy. But in the end, yeah, it comes out to you put in the videos, it learns from them what is and isn't.
So the videos, I imagine they're not just videos that you get from when the patient comes to see.
Oh, they literally are.
Yeah, that's okay.
Yeah.
Okay, but they don't have to have a little, I don't know, webcam or the iPhone and videotaping themselves at home.
Well, they could. That would be one thing we'd love to do eventually, right? Like right now, we're doing what we do for our patients in general. So in order to discuss people with our colleagues, we always have taken videos, especially at the first visit of our patients doing set movements. Those are the videos that we use. We shoot them on an iPhone, and instead of sharing them with our colleagues, we share them with the computer system. That's very different from having a product that you can put into a person's phone and have them use it from home. That is the goal, and I think we could get there fairly quickly, but that's not what we have in hand at this moment.
Okay. Let me shift a little bit from the diagnosis to the treatment. You talked about the fact that we have a storage capacity problem. The cells are dying, so you can store dopamine. So just replenishing it is insufficient after a couple of years. So what are some of the more novel ways to begin to address this problem? Is there a way to replenish the dead cells?
I'm excited to talk about that too here.
Please.
Because yes, it's the other end of the issue. For the folks who've already had changes, what do? Stem cells have long been a attractive focus for Parkinson's. It makes sense, right? You're losing cells. So logically, let's give cells. That's been hard to do in practice over the last 10 or 15 years for a variety of reasons. There has to be the right cells in the right place at the right time. And then the fourth thing is they have to grow up into the right kind of cells. Cells do different things.
We have minor problems. So how do we overcome? How do you overcome these barriers and get the right cells to make the right stuff in the brain where we need it?
Well, there have been decades of work on stem cells that have brought us to where we are today, to actually having stem cell trials. So there are trials of stem cell injection for Parkinson's disease going on right now. And in fact, we hope to initiate ourselves as a site for one of those trials in just a couple of weeks, on July 16th.
Okay. And tell us a little bit about that. What does that involve? And which patients you're going to treat and so forth. That sounds like a very exciting
It is
project.
very exciting. So this is a thing called bemdaneprocel. So that's a hard word to remember. I had to spend a couple of minutes outside trying to make sure I'd be able to say it correctly. Blue Rock and Bayer together are the company doing it. And the trial is going to be something called Expedite. Okay, what is it? There was a trial of just, I think, 11 people, so in between 10 and 20 people at just 3 centers in the United States, where they actually injected stem cells directly into people's brains, so a surgical approach. This is important to mention because, people have been trying to get peripheral stem cells to work for a while with kind of variable results. Injecting cells into the bloodstream, inhaling or injecting cells into the face are approaches people have tried, but there's something called the blood-brain barrier. Your brain, your central nervous system, is great at making sure it stays okay. Like I said, and I agree with it, I think it's the most important organ in your body. It can't get infected. And so the blood-brain barrier is a whole set of different strategies that your body employs to make sure stuff doesn't just go to the brain without having a lot of checkpoints at filtration. That's a problem for stem cells that are being injected anywhere. A lot of them get filtered out by the blood-brain barrier. They don't necessarily go where you want them to anyway. So it's logical. People have been trying for a while to inject stem cells into the right spot. But injecting stem cells, right, are cells that have not, that's worth mentioning too, have not yet picked an occupation, if you will. People are most familiar with embryonic stem cells, the cells that can become anything at all. But just taking undifferentiated stem cells that really have no purpose in life yet, and throwing them into an area and expecting them to work is a lot like throwing a bunch of babies into a boardroom and expecting like a functional board to develop. Like, there's a lot of stuff that has to happen in between. What's unique about this trial, I think, is that they're using dopamine cell precursors. So these aren't embryonic stem cells. These are cells that have been designed so that they will grow into dopamine-producing cells, through a whole series of really clever science that would take the rest of the time. So we'll let that go. And on 11 people who were injected with this, not a control group, right? This is just seeing if the thing has any reason to potentially be pursued. They seem to be seeing some pretty spectacular changes. We're waiting for like the full results. There are some results in Nature already showing really spectacular improvement in this cohort. But the people doing this are careful scientists and are not jumping out there and saying this is what changes PD, but this is worth testing. So here we are. This is the test. People are going to be in this for about a year and a half or so. These are people with advanced Parkinson's disease, people who would otherwise be candidates for deep brain stimulation or other sort of therapies for people who are wearing off and fluctuating a lot. And these people will be volunteering to have stem cells as part of the surgical procedure injected to their brains. By the way, I'm proud to say that as of a couple of days ago, we've been named as the implantation center from the Southeast. So everyone will be bringing their patients here.
So you think that's going to overcome the storage problem because you're going to have more neurons capable of storing dopamine?
I'm hopeful. Okay. This is what we're going to test.
That's so promising. It's exciting. Dr. Hack, I am so fascinated. I could spend the entire hour talking to you about this fascinating problem. And what's great is the way you try to elucidate things in such a clear and concise way that it's just been very enlightening for me. And I know the audience absolutely appreciates everything that you've done to teach us about Parkinson's disease and movement disorders in general. So thank you so very much. Now we know that you are truly the expert in movement disorders, and we are excited to look forward to the prospects of this clinical trial, because Parkinson's being a growing problem, I know that people across the globe are going to benefit from the outcomes of this trial. So good luck with it. And then I'm thrilled that it's happening at UHealth in the Middle School of Medicine.
Me too. Thank you for the opportunity to talk about this.
Wonderful. And this has been another episode of Inside Miami Medicine with the phenomenal Dr. Hack. Join us next time for another episode